going to start with ladies first and ask Debbie, is an ageing brain a declining brain necessarily?
Certainly not necessarily, no. We do know that as we get older, if we take serial scans and things, the brain does lose some volume, but the function of the brain is largely due to its circuitry and all of the neurons and things like that. So yes, the brain does lose volume and lose cells over time, as other parts of our body does, but it also has tremendous capacity as well to be able to be flexible and be plastic. So an ageing brain will change over time, but doesn't absolutely mean that you're going to lose it, so to speak.
Yes, and I understand that when we get to our 40s, not that I have reached that number yet, that this memory loss or the forgetfulness becomes more and more a part of our daily life. And are there remedies that you, as a clinician, would say for someone like me at the moment, who might be putting the iron in the freezer accidentally, perhaps hiding it on purpose, that you could recommend?
Yeah, I think a lot of people worry about that, and it is what we often call benign forgetfulness. All of us, if we're tired or a bit stressed, will often do things, forget where we've put our keys and things like that. And largely those sorts of things are just a benign forgetfulness. They seem to be a little bit more common in women, and they often occur quite commonly around menopause and things, but also later in life as well. And they're usually nothing too much to worry about. I think probably all of the people on the stage do it too.
Yes, that's good to know. Well, I do have a number plate here. JRU660. If that's your registration, you have left your car running in the car park, so you'll know what it looks like, I hope. May not be anyone here.
Do you know, so I think just picking up on something you said, Debbie, and the car reminds me of it. If you're 18 and you leave your car running and come into a meeting, you just think, oh damn, I've left the car running. But if you're 52 and leave your car running and come into a meeting and someone points it out, you think, oh my goodness, you know, is this, am I having a senior moment already? And if you're 82 and you come into a meeting and you leave your car running, you think, could this be Alzheimer's disease? So attribution is terribly important because 18-year-olds are forgetting their keys, going into rooms and thinking, why did I even walk in here? And forgetting someone's name that they've just met at a party all the time, but they never think this is the beginning of the end. So our own attributions are also very important.
That is very important. How do we know the difference between, if you're at the age of 50, say, normal cognitive decline and what we would say was perhaps symptomatic of early stages of mild cognitive impairment or dementia?
Sure, what the textbooks tell us to think about the most, Sue, is the problem impairing my day-to-day functioning? That's a line in the sand. It's a pretty good line in the sand. And that is one of the key things that as doctors we're all listening to really carefully when people are telling us, oh, I'm a bit worried about this or that my brain is not so good at compared to previously. But underpinning that is some good science. So it's the breadth of the problems that we're having with our brain. So not just in one area, but starting to be a bit more across several areas. And the depth or the severity of the problem. So just how bad is it? Is it the occasional forgetting where I put my keys? Or is it quite a few things and quite a lot? The frequency, is it often, a lot of the time, or once in a blue moon? But of all of those things together, it's the impairment in function that is the key. So that leaves me sitting in a clinic and no doubt my colleagues, if someone is saying, oh Doc, I'm really worried about my own memory, and no one else is worried, that's very reassuring. But if everyone else is worried and the person themselves is not, that is more concerning. I think you can instantly see why, but we all meet people that come in and say, I'm really worried about my memory, and you know, oftentimes we end up saying, do you know what, we're not so worried, I think you can relax with that one.
And you obviously take into consideration factors like stress or people being under particular pressure because they're moving house or changing jobs and things like that as well. Sure. And what about the stress of going through something catastrophic like what Christchurch has been? How has that impacted people?
From a psychiatrist's perspective, and I must say I was really pleased to be promoted by Nina to a neurologist. I've always wanted to be a neurologist, but as a lowly psychiatrist, I think the thing about stress has two effects on us, doesn't it? One is that when you are stressed in the moment, none of us function that well. All right, so in that moment when there is currently an earthquake or there's just been an aftershock, this is not a good time to do long division in your head. But it's the accumulative stress, isn't it, over months and months and years. And we didn't just have an earthquake, we had 1,000 and something earthquakes, and at some point, the way your body reacts to that, and in particular your brain hormonally and your heart and how everything's going, you reach a point where you can no longer function at top capacity, and this will affect your ability to do all the things that you normally do. But that does not mean that you're necessarily developing a dementia.
Yeah.
Tim, what would you?
Yeah, that's right. I think I don't think there's any good evidence that stress, even a lot of stress, will actually accelerate or cause any neurological disorder. But it's the anxiety and the constant anxiety and maybe depression that goes with it. It will sort of bring it out and maybe just enlarge what might be happening. And so if someone's beginning to become a little forgetful, then that will aggravate that problem with forgetfulness. Yes. But once the stress is relieved and the person returns back to normal life, then they'll come back to normality. So stress in itself won't cause any of these disorders, but they may reveal them a bit earlier than they might otherwise have occurred, or aggravate them if they're already there.
So how do lifestyle factors impact on alleviating this? We know that Tai Chi in particular is good for stress, and meditation and things like that, healthy eating. What's good for the heart is good for the brain?
That's absolutely right. There's no doubt that what's good for the heart, and we're learning this a lot more now, is good for the brain. And perhaps we're going to get onto it a bit more later in the discussion, but as people get older, there's cerebrovascular problems, people have problems with arteries and so forth, and when people get to older age, that interacts with other degenerative problems like Alzheimer's disease and so forth. So it's really critically important to look after those factors, and we know that exercise, diet, and we'll come back to that maybe, all those factors that look after blood pressure and your heart and your blood vessels will improve your chances of not getting neurodegenerative disorders and, for example, Alzheimer's disease. So yeah, very important, both I guess to help with stress and anxiety, but also to help prevent brain degeneration.
Thank you, Tim. Debbie, I'm going to start talking about brain disease specifically now, and I'd like to ask you, out of all of the factors that are involved in neurodegeneration or neurodegenerative diseases, there are various roots or shared commonalities. What in particular, and you're interested in multiple sclerosis quite specifically, do they have in common that you can talk to?
Yeah. So the brain, again, we go back to the fact that the brain really is 3 pounds of circuitry and cells and neurons, just the most incredible, fantastic structure that does all of these things with sort of 43 billion connections. And that any disease that affects any part of that circuitry is going to be cause problems, which will manifest in a number of different ways. And so there is definitely some differences, for example, in multiple sclerosis, where people have inflammation within the pathways, and I think you've put the axons, because of the myelin being affected. So those are the communicating wires that are affected, and that will obviously mean that the circuitry is disrupted. If you have conditions where you lose cells, The neurons themselves that too will mean that the connections are not able to be made. The brain is incredibly plastic, and so with different diseases, it tries to get around those problems, and it is a series of networks, and it can use other networks, but ultimately it becomes disrupted, and that manifests as a number of different conditions and dementias.
Yes, okay. So what about, sorry about that. What about things like cell death and loss of smell?
No, that's Tim's area.
Is it your area?
Loss of smell is curiously is a forerunner, for example, or can be in Parkinson's disease and to a certain extent Alzheimer's. So not all the neurodegenerative disorders, but particularly Parkinson's disease. And one of the fascinating things is that the loss of sense of smell will come before the sort of other common features of Parkinson's, such
And
as
often
tremor.
quite some time before.
Oh, many years before, yeah. And for Parkinson's, there's certain types of loss of sense of smell. The smell of pizza, for example, people who have trouble. Yeah, but people have to remember that there's a lot more common causes of loss of sense of smell. For example, smokers, blocked nose, sinusitis, head injuries. So, you know, many people will lose their smell, but that doesn't mean to say they're going to get Parkinson's or Alzheimer's. But if you take it the other way around, if you take people with Parkinson's and you test people's sense of smell, the majority, by the time they get diagnosed, will have an altered, not necessarily completely lost sense of smell. And there are a number of other factors, and we may come back to that, Sue, for Parkinson's in particular, and it's the same for Alzheimer's to a different extent. A lot of prodromal features that we now recognise as being forerunners to the development of the key features of Parkinson's, for example. And so now there's a big thrust to try and identify people who might be at risk of Parkinson's. And of course, that's a big thrust in Alzheimer's disease, to try and identify people who are going to be at risk of Alzheimer's disease, Alzheimer's dementia, many years before they actually develop the actual loss of memory and loss of cognitive function, so that when we have a treatment, a good treatment to help prevent that disease, you can identify people early and really nip it in the bud. But yeah, loss of sense of smell was a curious one, and it's raised questions about what could be causing, for example, Parkinson's disease, and it's one of the theories is that there may be something in the environment or a number of factors in the environment that get up into our nose and hit the smell nerve, the olfactory nerve in the nose, which then goes straight back into the brain, and maybe that's the portal of entry for whatever factor in the environment or factors initiating the cascade that leads to Parkinson's and maybe some other neurodegenerative disorders. The other theory is maybe something that we eat and it's getting in, or ingest and getting in through the gut, because we do find early changes of Parkinson's in the gut before it gets to the brain. So, yeah, these are interesting observations, and they lead to theories of causation, but also, more importantly, ideas about how one might be able to identify people before they develop their neurodegenerative disorder. And so that's a big thrust at the moment.
And I guess this is you know this because of the research work that you do. So you're obviously collecting data from patients and then being able to analyse.
Yes, yeah. Our particular interest in Christchurch is in Parkinson's, and my area particularly is Parkinson's, not so much Alzheimer's, but moving a bit into Alzheimer's, Matthew. Yes, so our particular research in Christchurch, and I'll come back to that later perhaps, is clinical research, and that's having patients with Parkinson's, perhaps identifying those people early after diagnosis and following these folks through. They're coming to see us and they spend many hours with us every couple of years, and we're particularly doing brain scans and doing very exhaustive neuropsychological testing to try and learn and to try and identify people who are going to have trouble with their thinking and memory, and in fact a type of Parkinson's dementia later in their Parkinson's career, so that we can, just like Alzheimer's, try and intervene at an early stage.
Yes.
So that's where we're going in Christchurch. Yeah.
And intervene to halt the progression
to try and
of the
prevent
disease?
progression, in particular for our little contribution is to try and help prevent the dementia that actually the majority of people ultimately, if they live long enough with Parkinson's, and don't have other disorders that take them away will develop cognitive impairment and oftentimes dementia. Not the same as Alzheimer's dementia, a different type, but dementia nonetheless.
Thank you, Tim. Matthew, to what degree are genes involved?
Genes are very important in all of these diseases that cause the brain to deteriorate over years. But it's not like a family curse. So there are very rare forms of these dementia illnesses that do get passed down in families, and by looking at those quite unusual families, we can learn about the more common form. But most diseases, Sue, not just brain but across the whole body, have a very strong genetic component. But it's not a gene that causes trouble. It's a large number of genes, mostly unknown, that each have small effects. And many of those effects, as we uncover them, are effects on the way that organ, in this case the brain, handles known risk factors. So, for example, people may have heard or read in the Listener, that great medical journal in New Zealand, that inflammation is one of the smoking guns in dementia. So some of these genes, which we all carry to some degree, that affect how our inflammation behaves, may protect or raise our risk of a different type of dementia. So since you can't change your genes, and since they're a very big part of the story, that's why a lot of the focus now is on those lifestyle things that we've just started to talk about, which are under our control, which even through into late life, if we improve or optimise them, might lower our risk of developing a dementia further ahead. So that's where a lot of the focus is now heading. 10 years ago, dementia prevention was not a thing, but it is now a thing. And all of us in this room, whether we're living with dementia already or not, there are things that we can do to improve our brain health, even into old age. So there's a lot of attention on that now.
Very interesting. Can you tell, there's a lot of confusion about dementia and Alzheimer's disease. Can I ask you to explain what is Alzheimer's disease and what is dementia, please?
It's a great question. I was just thinking, we're using these terms a lot, aren't we? Up there, neurodegenerative disease, dementia, Alzheimer's. What are we talking about? So, I think, Sue, a really good way of thinking about it is that lots of us have heard of heart failure or maybe liver failure. But we've never heard of joint failure. That's because we've got a code word for it. We say arthritis. And there are code words for some of the other types of organ failure too. Well, with the brain, when we have a disease that gradually over the years affects the brain's ability to do its normal work in a chronic and progressive way, instead of saying chronic progressive brain failure caused by a degenerative disease, we say dementia illness. So it's like the umbrella term across the whole lot. Underneath that, there are many, many diseases that could cause this in humans. But the commonest by far is this one that everyone's heard of, Alzheimer's disease. But there are others. So we've heard about Parkinson's disease with dementia.
MS with dementia.
Yeah, MS with dementia, frontotemporal dementia, vascular dementias, dementia with Lewy bodies, and alcohol-related dementia. That's the big six in New Zealand. But there are many other less common ones. So dementia, umbrella term, Alzheimer's disease, one of the diseases that can lead you there.
Yeah.
Thank you.
Can I add to that, Matthew, if that's okay? And I think the other important factor is to realise that the Alzheimer's pathology, which is, we'll come to no doubt, the plaques and tangles, the pathology starts many years before the cognitive change. And so some people out there in the literature talk about Alzheimer's disease as being separate from the dementia due to Alzheimer's disease. And so the pathology, and actually from those rare disorders that Matthew was talking about, the rare genetic disorders where the Alzheimer's disease and dementia is passed on down through the family, very rare, they've taught us an awful lot about how early these changes can begin, and the commonly accepted sort of feeling is that 20 years, the changes, the Alzheimer's pathology changes, start 20 years before the cognitive impairment, approximately, depending on other factors. And so the Alzheimer's disease in some ways is starting well before the dementia due to Alzheimer's disease, just to reiterate Matthew's point.
Very interesting. Matthew, I just want to go back and clarify something, because Nina referred to you as a neurologist. She put you in the collective. And so I'd like you to...
Very flattering.
Well, in the old days, psychiatrists and neurologists were together. It was, we were sort of combined specialty.
You were friends back then, yeah. and so you are an old age psychiatrist, or a psychiatrist that works with older people's health. Can you explain that?
So I think perhaps the place to start is the difficult word is psychiatrist. Yes. So a psychiatrist, Sue, is just a doctor who, after general medical training, has gone on to specialise in problems of the mind. So that's problems to do with our thinking, our feeling, the perceptions that we get through our senses, and our behaviour. But our mind is just another way of looking at our brain, which is what my neurology colleagues are primarily looking at. But we have such tremendous overlap that a good psychiatrist must also think brains, and a great neurologist must also think minds. And that's why we're here together, and we work together in this city, because this whole idea that the mind and the brain are different is, I think, clearly false. As you'll quickly understand if your head is ever chopped off, your mental life will change rapidly at that point. So it's two sides of the same coin. So a psychiatrist of old age is bringing that approach to the problems, the strengths and the challenges that are more common and sometimes peculiar or special for older people.
Thank you. Debbie, now I'd like you to explain the word neurologist and also the specifics around subspecialising.
So neurologists, as Matthew alluded to, have sort of grown up through a tradition of looking after people who have diseases of the nervous system. So that is things with the eye, brain, spinal cord, nerves and muscles specifically. And Matthew is right, there is an awful lot of overlap, and I think as the years go by, we will become less and less separatist and appreciate that our minds control a lot of our... But we tend to focus on structure and function of diseases of the neurological system.
Right.
Yeah, and I guess if I can add to Debbie's, neurologists, we deal also with people who have symptoms but no particular abnormalities, so they don't have diseases. So we all have neurological symptoms, dizziness and headaches and things like that, where there's no underlying disease that we know of, but we still have to treat the symptoms. And so that's also what neurologists do, particularly on an outpatient basis.
And I think where we overlap a lot is that probably about 20 or 30% of the patients that Tim and all of us as neurologists see are symptoms that we don't always find an actual anatomical cause for, and that we often can display a lot of symptoms that have a neurological flavour, but in fact symptoms that might worry a person but really have no underlying disease state. They're very real, and they occur in a large percentage of the population. And so some of our specialty is trying to work out and ascertain which symptoms mean that there's some underlying pathology and which symptoms are problems with the software within the brain rather than anything. And we all have different areas. Tim specialises a lot in Parkinson's disease, although we all do. Other doctors in stroke, and myself in multiple sclerosis. So there's lots of different areas.
I'm just going to stay with Alzheimer's disease for a moment and stay with you, Debbie, and ask you to explain this MRI scan here.
Oh, I might get the others to.
Okay.
I could explain that, but it might be better by Tim.
All right.
Or by
Tim,
Well, I could start.
you've got a nice big 3T scanner.
Yes,
Yes,
we
we
have, and this looks more like a blood flow scanner to me. And if you look at the image on the left, the normal person, the healthy person, we're all normal, but this person looks to be healthy, and it looks to be like blood flow, and the red areas are the cortex, the thinking, and a part of the brain in particular. And the red usually means good flow, and the blue, don't worry about the blue because there isn't meant to be much flow there. That's normal to have that blue, but it's the outside bit, the rind bit, which is the cortex, and that person's got very healthy blood flow, both at the front and at the back.
Yes.
In the middle, the person, and no doubt we'll come to what mild cognitive impairment means, and Matthew's already touched on that.
Yes.
You can see that sort of 3/4 of the way back on both sides of those cerebral hemispheres. So the front of the brain's up the top and the back of the brain's at the back, and in the more of what we call the parieto-temporal lobes, there you can see there's green and not much red. Do you see that? And that means that there's already beginning to be loss of blood flow and loss of what we call metabolism, glucose uptake. And then the person who's developed the dementia in the far right side, the third one, you can see that that's become emphasised, and the person's probably developed some atrophy as well if we look at them more closely. But that is pretty characteristic of the sort of pattern that one sees in the dementia of Alzheimer's disease, the loss of blood flow in those particular parts of the brain.
And
Do you want
could
to
I,
add to that, Matthew?
well, Matthew, would you like to explain the atrophy that we're seeing in the next slide, please?
Well, you might have noticed that as you get older, lots of things atrophy a little bit. And the brain also does this as part of normal aging. But in normal aging, most of the shrinkage of the brain is the result of the cells in the brain losing size, losing volume. There is some loss of cells, but it's not as pronounced as people think. There's an urban myth about losing 1 million brain cells every week or something since you were 18, but this is not true. But with Alzheimer's disease and other neurodegenerative diseases, there is not just accelerated change in the shrinkage of nerve cells over time, there is also the death and loss of nerve cells over time at a greatly increased rate compared to normal aging. And that's what you can see if you look at the severe end of an Alzheimer's brain there and compare it to the healthy brain. If we were to look with a microscope, we could see that not only is the total volume smaller, but the numbers of cells have decreased, and the numbers of supporting cells have decreased, and there's also some inflammatory cells mixed in there as well, trying to mop up some of the mess and fight fires which are too late to fight. So those are all the changes that we might see, as well as some of the specific things for Alzheimer's that Tim mentioned before, that some of you may have read about, called plaques and tangles, but we could only see them with a microscope.
Can I just pick up on something that
Sure.
you were saying before with the scans? That I think one of the things that Tim and Matthew were saying was this importance of trying to, now that there may be treatments for these conditions, and also how we now appreciate that lifestyle changes are very important, that the scans here, and these are the sorts of things that have moved and the technology's moved forward, where we may be able to identify people before they have symptoms, or if people come to us with symptoms, we can do these scans and either reassure them or say, well, maybe there are some changes, maybe we'll keep an eye on you. And if we can find something like this and image people early, we may be able to give people the opportunity to make lifestyle and other changes that will help delay the difficulties.
Although we'd have to hasten to say we're probably not there yet.
We're not quite there
except
yet.
as a research tool. But that's definitely the thrust of the research in Tim's group. It's really exciting what we're starting to peel back there in New Zealand. But around the world, this is the beginnings of trying to pick people early and intervene in a meaningful way. But folks, you can't ask for that from your GP yet. But that's where we want to move.
And the beauty of the work that you've been carrying out for the past 7 or 8 years, Tim, is that you've got the same patients, you've had them in scanners for various periods of time over those 7 or 8 years. So that's very unique, isn't it?
Yes, I think we're keeping pace with some of the rest of the world, and the reason why we can do that is there are fantastic populations here in Christchurch and in New Zealand generally. We're really well placed to do some clinical research with people with conditions of the brain, because Christchurch, for example, is large enough to be able to do that with enough population, but it's not too large that people are scattered and there's lots of different hospitals competing. And we have a stable population. You know, our folks, despite the earthquakes, don't tend to move around too much, whereas in other countries there's a lot of movement. And we have patients who are really willing to help us with research, and so we're the envy of a lot of the world for that very reason. So we can do good longitudinal studies, and the Christchurch longitudinal study has been going for many years, very famous. The Dunedin study, even more famous. So we're well placed to do this sort of clinical longitudinal research, serial studies of patients who are willing to come and help us. So that's been a boon, but it's mainly because our patient populations are so willing, really.
Fabulous, and it's great to have a brain research institute in Christchurch, based here as well, that you can collaborate with neurologists at the hospital and scientists at the university.
And if I can make a wee bit of a plug, so here in Christchurch we're part of what's called the Brain Research New Zealand Core, Centre of Research Excellence, which is collaboration between neuroscientists and neurologists and neurosurgeons throughout the country. And as part of this big collaboration, research clinics are going to be starting, or have been starting in Auckland, and will be starting today in Christchurch, trying to recruit people who have what's called mild cognitive impairment, and that's the middle panel of that on the slide you've got there. People who haven't reached dementia, but who have just got a little bit on the way towards that possibly. And we're trying to recruit people, we will be, if anyone is going to be in that category potentially, and to help us with our research. And those folks will come in and be thoroughly and exhaustively gone over, and we'll be having scans and a lot of blood tests, and the blood will be stored for future research, and they're going to be starting next year. So just sort of keep that in mind if you have an interest, and Matthew might well be involved in that as well.
And there is a website, brnz.ac.nz.
Yes, there is, you could look at,
So details of the clinics will be on there.
Thank you for that plug.
Thank you. So on the screen now I have a graph. Matthew, I'm going to ask you please to explain this, and if you can also interweave into this how you diagnose someone with MCI and then with dementia.
Sure. So what this graph neatly demonstrates is that if we imagine a person who over 10 years will develop a dementia illness, then if we follow the line from the beginning to the end, that's what it might look like. All right? So the vertical axis, the vertical side of this picture is measuring brain function, starting at normal and gradually, unfortunately, because of whatever disease, whittling away at that brain's ability to do brain work. But what that means is that that person will go through a period when they weren't able to use their brain at the same level that they could before any symptoms began. However, they're not so bad as they will be in another 5 years when everyone agrees, oh my goodness, I'm so sorry that you've got a dementia illness. So they go through an intermediate period. However, if we now stop thinking about this graph and round up 100 people in Christchurch who have this apparent mild troubles with how well my brain works, only half of them are on that track. The other half are temporarily not working as well as normal and will bounce back. Maybe I'm depressed, maybe I've got some disease somewhere else in my body, maybe I'm very stressed because of the earthquakes for 2 years. And another proportion of people, quite mysteriously, have declined in function and then stop. No worse, but no better. Now, where that line in the sand between dementia and probably headed in that direction, but just at this thing that we'll call mild cognitive impairment. This line in the sand is the line of significant impairment of functioning. Behind that is also, if you do brain power tests, they are more than 2 standard deviations worse than someone else their age and stage. But that's the line. All right? So that's this concept of mild cognitive impairment. And Sue, what we're so interested in that group for, even though half of them are not on this line, is that this is the group that if we could intervene, then we might be able to stop the tide from coming in. So once again, we're not there yet, but that's where we're focusing most of the study attention.
And when you say intervene, do you mean therapeutically or
Yes.
with lifestyle change?
Both.
Yeah.
Both. Lifestyle change starts at the top, and that's probably where it's most effective. But thinking about medical treatments and medical technologies, and also thinking about specific and targeted brain training, then halfway down the line, that's where those things might have the most impact, but it's still too early to say that for sure. But that's part of what you're doing, I think, Tim, to look at that.
Yeah, correct. And just to reiterate Matthew's point about the fact that you can be on this, the curve that goes down towards mild cognitive impairment, but that's not, that is a bit of a slippery slope. But as Matthew says, not everyone keeps going. Some people just stay exactly in mild cognitive impairment. Half the people with mild cognitive impairment go on to get Alzheimer's, dementia. But as Matthew says, some people bounce back into normality, and we've seen this in our Parkinson's research. This is not Alzheimer's, this is Parkinson's, but we still see cognitive decline in Parkinson's towards dementia. And we do these careful tests every 2 years, and we get surprises. We make a diagnosis of mild cognitive impairment in Parkinson's, and then we do the same test 2 years later, which is what we do in the same patient, and find they've gone back to normal. So just because you fail a test, a bit like failing a driving test or anything else, on the day or on another day doesn't mean to say that you're permanently at that level, and you can bounce back. So these are just sort of labels that are made based on a variety of factors, symptoms, but also cognitive testing, and cognitive testing varies from day to day, and so nothing's inevitable in this world.
And I guess things like sleep deprivation also affect the testing.
Yes, So, cognitive testing. These days at the GP, many of you out there would have had that. They do a thing called a mocker test. It's a series of questions, and you've got to get a certain score. And we've seen huge variations. So we'll see, and Matthew will see this more than I, that the general practitioner has seen a patient and said, oh, the mocker score is really low, and send them along, and then you do the mocker, and it's almost normal, And so it varies an awful lot depending on how anxious the person is, how they're feeling on the day, poor sleep, taking a medication that interferes with their memory, all sorts of things.
Okay.
So one's got to be cautious.
I notice on the graph here on the y-axis that there's no numbers. Are there averages in ages when you can expect that MCI is going to become something that is more commonly diagnosed?
Yes, but great caution should be attached to that. MCI, mild cognitive impairment, it's not a disease. So it's not really a diagnosis, it's a description.
Right.
It's a description of a risky state. By risky, risk in terms of how doctors think about risk. So it's a complicated concept. But there is no doubt that whether you're on a track to having a dementia illness or not, and most of us are not, that aging is the strongest risk factor for not being as good cognitively as we used to be. So at 90, we may do less well in whatever test we choose. Is it the test of being able to drive a car? Is it the test of being able to remember something someone has said to us in a conversation? Is it the test of doing the mocker with my GP? At 90, I won't be as good as at 70. At 70, I won't be as good as at 50. So aging does have something to do with it, but it doesn't explain it completely.
Okay.
I was interested in what Matthew was saying about exercises, and I'm sure
Yes.
people have been very interested in these mind exercises. I've just returned from London, and I was talking to one of the cabbies there, and they did some studies. You know, everybody who's been to London's been around in a black cab, but I think it's a dying breed with Uber coming along. But anyway, the black cab people in London were involved in an experiment a few years ago, and these guys learn all of the London streets and all of the places that people go to, and they spend about 6 hours a day mentally going through the maps of London, where Waterloo is, where Trafalgar is, and driving through in their minds and calling out routes and describing them. And when they looked at their brains, the hippocampal areas, or the areas that really engage in this kind of thing, had expanded enormously in a sort of a focal way in these people. And the more they drove and the more they did, the larger it got. So there is plasticity there, and these are things that we may be able to tap into in the future.
That's a brilliant story and a brilliant example, thank you. I'm going to stay with you, Debbie, and I'm going to ask you, please, if you can talk to the stroke slides that we have in here, and there'll be a lot of people here this evening that are interested in knowing what the risk factors are, knowing what a stroke is, the two types of stroke that there are, and what are the effects on the brain, and is this an ageing disorder?
Stroke, there are two types of stroke. There are strokes which occur when a blood vessel is blocked, what we call an ischemic stroke, and then there is a type of stroke which can occur when there is a breakage in a blood vessel and you get what we call a hemorrhagic stroke. And there are a lot of risk factors which obviously predisposes to stroke. In terms of age is certainly the highest risk of stroke. As we get older, our blood vessels get more and more furred up and they get stiffer, and of course our risk of stroke becomes higher. But there are a number of other risk factors obviously that can occur, and very reassuringly, if you look worldwide at the moment, the risk of stroke is dropping enormously. Now that may be largely due to the better lifestyle that people are leading, more use of antihypertensive drugs and things like that, but it is certainly the risk of stroke in many countries is decreasing significantly. When I was a physiotherapist 20 years ago, I used to look after a lot of people and retrain people with stroke. And the feeling at that time amongst the medical fraternity was that once you've had a stroke, the brain is dead and you could learn to find little tricks to overcome it, but that you wouldn't be able to improve what had been damaged. We've changed our opinion a lot about that, and obviously the brain is now thought to be a lot more plastic than we thought. And whilst with large strokes there are parts of the brain that may not recover, the amount of the ability of areas around that to change and to improve. And one gives an example of in a young person, a young child can have a stroke and lose half of their brain. And they may have a little bit of weakness, but otherwise they learn to function well, they go to school, and they recover very well. As we age, that flexibility is slightly less. And I think you've put up a picture of Kathy Skinner's wonderful work in Auckland. And this is using a type of stimulator which they put across in the brain, which primes the brain to be more receptive to inputs that are coming in and to help in rehabilitation. And the group in Auckland have been doing some marvellous stuff, looking at ways to enhance rehabilitation after stroke, because it is such a devastating condition for so many people, and it takes away their ability to work and do lots of other things. The other really exciting thing with stroke is that if we can get people early after their strokes, we can intervene now in ways to try and reduce the amount of damage. For a number of years we've had what we call the clot busting treatments, And so this is why there's been a lot of advertisements about coming to hospital with stroke, the FAST programs, so that if you get to the hospital within 2 to 4 hours of your stroke, there's a very good chance that we can give treatments that will help. The thrombolytics, the clot-busting treatment, but also now there are, and certainly in Christchurch we're doing this, where we will actually put catheters in and retrieve clots, what we call clot retrieval. And so these are very exciting, and there is nothing quite as heartening as seeing a person who's come in with a dense stroke, who we then take to the theatre and retrieve the clot, and the next morning you go and see them and they're moving and talking again.
And essentially you're saying time is brain.
Time is brain. And the earlier we can get people to come in, the more likely we are to be able to intervene and help the brain.
I'll just go back to this scan here, and can I just ask you to explain what's happening here?
So what that is, that's an MRI scan, and when we do MRI scans, we do them as if we're standing looking at your feet. So on the right side, where you can see the arrow, that's the right side of the brain, and the other side is the left side. The dark stuff is the brain material, and the white bit in the middle is the water cavities within the brain. And what is not normal in that scan is that large area that you can see on the right-hand side, which is sort of over the right part of your brain here, that is pale and swollen. And what that shows is that one of the arteries that feeds that area of the brain has been blocked, and the brain is swollen and basically ischemic, what we call ischemic. It's lost its blood supply. It's probably largely damaged when it's that swollen. We like to try and intervene before we see those changes.
Because this is massive, isn't it?
It's a large stroke, yes. And it, of course, the area in which the stroke occurs determines what symptoms that you get. So this person here will have difficulties with their left side, probably their arm and leg, and possibly also their speech, because we know that on the right side of the brain, controls the left side of our body, and so this person may have problems with their left arm and leg.
I'd like to showcase some of the research work that's been going on in New Zealand now, and I'd like to start with you, Debbie, if we can. And if you could just talk to us, explain multiple sclerosis as a disease, and then talk about some of the research work that you've been doing specific to New Zealand's population.
So multiple sclerosis is a condition which is quite common in New Zealand. It is a condition where the white blood cells, for reasons which we still don't understand, become kind of dysregulated, and they move around the body and move into the brain and attack parts of the brain, particularly the myelin, which is that insulating substance that's wrapped around the connections within the brain called the axons. And we've now got really very effective treatments for many types of MS, not all, but there is still a lot that we have to learn. And Tim was talking earlier about the fact that New Zealand has this amazing ability to do clinical research, and so we have been doing a number of studies across New Zealand, and in 2006 we were able to identify everybody in New Zealand who had MS and gather an enormous amount of data. People were extremely generous in letting us know about their disease and how it affected them. And we've been continuing to look at those results and analyse them, and we've recontacted a lot of people, and we've done another more recent one to see how MS is affecting people who have been diagnosed more recently. One of the fascinating phenomenon about multiple sclerosis is that it is much more common in southern climes than it is in northern climes. It's this thing called the latitudinal gradient, and nobody really knows why that is. And New Zealand's a lovely country to study that, because you've got Northland up here at about 34 degrees latitude, and then you've got right down to Invercargill and Stewart Island at about 46 degrees. And what we showed is that there's an enormous difference between the risk of MS in Auckland compared with Invercargill. Your risk in Auckland is about 50 per 100,000. In Invercargill, it's about 120 per 100,000. So this makes us wonder what it is about the southern parts of the country that are different or adding to the risk. And our most recent study, I can tell you this, but I have to tell you because it's not published yet, but shows that not only is there this large difference, the differences between 30 years ago when Professor Skegg did his initial studies and our ones that were done over the last few years, shows that the rates within Auckland and the northern regions are almost the same. In the South Island, it's increased further by about 8 times. So there's something in the environment that's driving that. And that's a wonderful opportunity in New Zealand now to study that.
Are you involved in Brain Research New Zealand?
I'm involved in Brain in the NZBRI with a Christchurch group, and of course we've had support from MS Society and from the Neurological Foundation.
Fabulous. Tim, why do New Zealand researchers, so that's clinical researchers and scientific researchers, punch so high above their weight?
I mean, I don't think I exactly know. I think we're enthusiastic. We lack certain resources in terms of money, although the Neurological Foundation has been incredibly generous. So we have to work hard to try and do with what we can with the resources that we have. But I think principally it's because the population that we have. I think, as I explained before, we have a very willing population willing to help us, and I think that's a critical feature. The other thing is that we have a great collaborative, especially in neuroscience. As you know, we have a great sense of collaboration between the scientists, neurologists throughout the country. You find in larger countries they're very competitive, even within a city. In Australia, that's quite competitive even within Sydney and Melbourne. So we have a very good history of collaboration here, and so we can actually tap into our colleagues from different cities and have research going. So I think there's, for the same spirit that says for patients to come and help us with our research, we also help each other as scientists and clinicians, and I think that's the reason why we do so well.
I think the really impactful thing that I have witnessed over the past 6 years with the Neurological Foundation is the commitment that people in neuroscience and neurology and old age psychiatry make to their careers. One of the first researchers, neurologists from Dunedin, that the Neurological Foundation funded in 1971 was still doing research 40 years later, and would still be if his wife let him. But she said, darling, you have to retire at some time.
You get hooked on it.
Yeah, absolutely. I guess there's so much exciting and fresh and novel stuff happening.
Well, exactly. Yeah. So, things that we never contemplated when I first started as a neurologist. We didn't know, we thought Parkinson's, for example, had no genetic contribution whatsoever, and now we know that it has quite a big genetic contribution. So the exciting thing about, in fact, both clinical work and research is that there's new things happening all the time which keep you fresh and interested, and surprises come and hit us and say, oh gosh, that's a brand new way of thinking.
It must be incredibly difficult for all of you to keep up with publications and what is new.
Correct, yeah. In fact, we can't in the board field. So I'm amazed that general practitioners can do what they can do because they've got to keep it.
That's right.
You know, they've got to keep it everything. But we subspecialise, and so that helps us. But we use things like Medscape and some broad search engines like everyone else. And we occasionally go to Google, and you know, we're just the same as everybody else. But we have to go searching through the literature.
Yes.
Yeah, but these sort of search engines have made life a lot easier.
Yeah.
We have to go on overseas trips to meetings.
Yes, getting three clinicians in the same room at the same time is quite difficult. Thank you. I'd like to talk about the future now because it does look positive, and I do take your point, Matthew, that we're not quite there yet, but there is a lot of exciting things happening, and as Debbie's just talked about clot retrieval and the clot busting drugs and things like that. So I'd like for us just for a moment to focus on some of the exciting things that are happening. And I discovered that in Germany they have these mobile vans, the red van that we've got on the slide up here, which are called STEMOs, and they're mobile stroke units, and they have a scanner that the patient, so the 111 or 000 or whatever it's called, and then if it is a stroke and it's diagnosed by a paramedic or one of the ambulance officers as a potential stroke, then straight into the scanner, and then the clot busting drug can be administered. How likely is that to happen here? Because I think there are 45 or 50 of these STEMO vans in Berlin now.
Yeah. I mean, I think this is one of the big challenges in New Zealand. We have a very large geographical area, and there are lots of places in the country that don't have neurologists or neurology units. So if you have your stroke in downtown Christchurch, then you're very likely to get thrombolysis and clot retrieval if it's appropriate. If you live in Bulla, then you're not going to be able to get that because by the time we get people here, it's too late. And so we've got to think about smart ways of being able to administer these wonderful treatments equitably across the country with a lot of geographic constraints. And that's a challenge. And I know that Dr. Fink, who's...
Dr. Fink,
there,
yes. And Dr. Teddy Wu.
And Dr. Teddy Wu and Dr. Barber looking, in fact, they've got a meeting coming up, looking at how best to administer this kind of care and get it out to everybody that needs it around the country.
And I've got Dr. Teddy Wu's photograph up on screen because he is currently on a Neurological Foundation V.J. Chapman Clinical Research Fellowship. Now, he's a neurologist, and we've sent him over to Melbourne Hospital, and he's working there. And one of the skills that he's acquiring on his fellowship is telemedicine. So, and he's hoping to bring that back potentially to Christchurch, where he'll possibly be working with Dr. Fink.
He is coming back to Christchurch.
He is coming back to Christchurch, yes. I didn't know if that was a secret or not, but yes, he is.
Coming back to Christchurch, yes.
He's fabulous, fabulous. And this is a big part of what the Neurological Foundation does as well. And as Nina said before, we send young emerging researchers overseas, but we do bring them back. And it's fabulous to think that this 20 years ago, the stroke patient was the last person for a neurologist or a clinician to see on the ward because, as we discussed before, there was no hope, but now there is. I'm going to talk about Parkinson's just for a minute, and I'm going to ask our techie if we could please have a look at a very special video that we've got here. Now, this is
Hi, I'm AJ. I'm 39 years old and I suffer from Parkinson's disease. I was diagnosed 4 years ago when I was 35, and I've since undergone deep brain stimulation surgery. This is a procedure whereby 2 probes are dropped deep into my brain and hooked up via a wire down my neck to a pacemaker in my chest. This provides a steady stream of electricity to my brain per second. So it has had a major effect on my life and a major effect on my family's life, which is the main thing.
We might just stop there, folks.
Today I'd like to show you what happens when I turn my neurostimulator off.
Oh, speak your pardon.
Now, it's just after 11 a.m, so it's time that I had my second dose of medication for the morning. So my first dose is pretty much all but worn off. So this is a good example of what I'd be like when I'd be sort of off, with no medication in my system and no power. To show you the dramatic effect, I will demonstrate. This is me with the power on. I'm not making happy little faces for the video. These are tests that the neurologists make us do to test our reflexes. As you can see, they're wiggling, moving fine, and I've got very good movement. This is the remote control, and this checks that I'm on. On and okay. And this is me when I turn it off.
Instant.
You won't be able to read that, it's shaking too much. So it's almost an instantaneous reaction. I can't control this. Could shake some quality cocktails with the right. The left just looks like the royal wave. My voice is gone. It's harder for me to get words out and speak. I'm completely rigid, and if I tried to stand up I'd fall. If anyone thinks I'm faking this, I'm not. I can't control the tremors and dyskinesia. The twisting in my neck is called dystonia and is really quite uncomfortable. So, as you can see, the tremors are getting much worse, and I'm in quite a bit of discomfort, and I'm about to drop the remote control, which will be fun because I won't be able to turn myself back on. So I think party time was over. Almost automatically. The power comes back on, I'm steady. So, if anyone's considering DBS, I thoroughly recommend it. It is life-changing.
2.3 million views on that YouTube video. He's a Neurological Foundation supporter, and he has given me a lot of time so that I could write stories in a headlines newsletter and talk about the progress of research. And this is now available, the surgery in New Zealand. It is only at Auckland City Hospital at the moment. But Tim, can I just get you to explain the procedure, please?
Yeah. Okay, so to clarify a couple of things with the video, or explain. He said it started in his 30s, and so there are people with Parkinson's where the condition starts 30s and 40s, and I certainly have patients of that age, where it differs from Alzheimer's in that regard. Parkinson's is not Alzheimer's, it's different, and can start at an earlier age. The other thing to point out is that you notice that when he was off, in other words, the stimulator wasn't switched on, he had a lot of tremor like that. Now, that's not the typical tremor of Parkinson's, it's only if someone's got very severe Parkinson's. So people who've got tremor like this, and many of us do as we get a bit older, that's not Parkinson's, so I want you to be reassured about that. The diagnosis of Parkinson's depends upon three things. One is a rest tremor. So the tremor that people with Parkinson's have is when the arm is at rest, just sitting, as you many of you, with your arms in your lap, and you're not using it. And that's when the tremor is apparent in Parkinson's, more on one side than the other. And tends to get better when the limb is moved. So, but he's obviously the severe stage and has got the tremor up there, so that's just one thing to be clear about. So the deep brain stimulation involves putting a probe into the brain when the person's awake on the theatre, into each side of the brain, one probe in each side of the brain, and it goes deep into the brain, into a part of the brain called the basal ganglia. And it's attached, that wire is then coming down to a magnet, and the magnet turns the stimulator on or off, and the stimulator sits in the chest here. And the stimulator stimulates at a very high frequency, about 100 hertz. And so there's if you like, electrical impulses, very small, going into the deep part of the brain at a very fast rate, and that's turning off that part of the brain. It inhibits that small part of the brain where the end of the tip of the stimulator is in. And that turns off that part of the brain, and that stops the tremor, as you saw, and also improves the slowness of movement. So the other critical feature of Parkinson's, the motor feature, is slowness of movement. Whereas I can do that at that speed. As he said, this is the test that we do as neurologists. People with Parkinson's have a much slower movement, and then it peters out with time. That's called bradykinesia. And that's actually the symptom and the feature that troubles people most, very slow movement. And this deep brain stimulation also speeds up people's movement. And for some people, it's just the most amazing sort of turnaround from being off and barely able to move to being really able to move well and live a really good life. It's critical to remember that the benefit you get from the stimulator is no better than the best benefit you get from the drugs that we use. We have good drugs for Parkinson's, but it gives you much more surety. The problem with people when they've had Parkinson's for a while on drugs is there's a lot of fluctuations, and people switch on and then they get too much movement and not enough movement, and it can be a real bugbear in their lives. But this stimulator allows them to be smoothed out and to be, have the same sort of status throughout the whole day. So it's really useful for people who've got normal cognition and are otherwise bedeviled by these fluctuations with their drugs. Yeah.
And this is now being used or tested for depression?
For depression, yeah. So there's many of this, people are trying it because it's just one part of the brain. There are other parts of the brain that get affected in other disorders, like dystonia. People have tics, depression, severe obsessive compulsive disorder, quite a number of psychiatric disorders, Matthew, where it's been tried. It's moderately still experimental. I think that's fair to say.
I think very fair to say it's experimental.
Yeah, but exciting. It's not the panacea for Parkinson's because Parkinson's involves other parts of the brain as well as time goes on. So it won't stop people's balance. It won't help the balance that some people have difficulties with. It won't help speech, which can be difficult. So it's a great thing for the motor problems, but it's not a panacea for everything.
The greatest reward that it gave AJ was the ability to hold a book so that he could read nighttime stories to his children. And I think that's really lovely.
Yeah, fantastic story.
Speaking about, continuing with the theme of future, Matthew, how far off are we, do you think, in being able to slow down the progression of Alzheimer's disease and that sort of theory?
Some of you
in our
have heard this
lifetime?
quote before, but
Yeah.
Niels Bohr said, prediction is very, very difficult, especially when it's about the future. And I think, although medicine is full of stories of incremental processes driven in a reasonably expected way by science, it is far more full of surprising advances that no one could see. Penicillin, probably the most striking advance in medicine because a bit of a mold flew through the window and landed on a plate of glass. So nothing to do with the scientist, but the scientist noticed it. So in Alzheimer's, I think if we're realistically speaking, the big thrusts of research at the moment, and some of the related dementia illnesses too, should leave me within my practice lifetime being much more accurate in terms of risks, being able to say, I think this is very risky for you, I think this is less risky for you, and therefore being able to give people tailored advice about lifestyle and maybe some medical treatments that will adjust the course.
Right.
I am not sure that we will have something that stops these diseases in their tracks in my practice lifetime. That would be brilliant. and I'll be a prescriber. But in the meantime, we're focusing on quality of life. And the single biggest advances in dementia treatment across the board in the last 20 years in this country and around the world, in my opinion, have been the move towards timely diagnosis. So calling dementia what it is in a caring and careful way, but calling a spade a spade, because without a diagnosis you cannot open the door to things that can help. And secondly, the move away from just thinking that the management of dementia is great medical care, because actually we haven't got a lot of medical technology to offer. The heart of good dementia care is caring, but in very focused and skilled ways. And it's that change, the change towards really informed, scientifically based, person-centered care has been the biggest clinical advance. Do you know, I sometimes think that I'm almost lucky to work in a field of medicine where the medical technology is not that good. Because 100 years ago, the medical technology wasn't that good for anything. We had a couple of dreadful operations, some odd remedies that didn't work that well, but we were really good at telling you what was wrong and whether you'd die sooner rather than later. But what we had 100 years ago that I think our grandparents' parents found very useful was an ability to care and just be there with people, but in a very focused way, not in a passive way, in a very focused way. And I think in dementia care, we haven't lost that. Now, I hope that if the cure comes out in the next 20 years, we won't all be running around like headless chooks, injecting people and scanning people and racing around so much we forget that the heart of it will still be caring.
It's an excellent point, Matthew. Thank you. Debbie, I'm going to ask you a question now, and this is what everyone is going to be wanting to ask at the end of tonight. What can we do to optimise our brain health right now? And I'll put this wonderful picture up.
Well, I think one of the most important things is that the things that have been shown to help our brain health don't have to cost a lot of money. I think we all as clinicians see patients coming in with some very expensive products and supplements and various things like that. And you know, there may be a place for some of these and there is experimentation looking at whether these help. But if you look at the studies, the studies with, I wrote it down, the religious orders studies.
The nun study.
Religious order studies looking at nuns and priests and a large cohort of people and who do better and who don't. And the bottom line is it is about maintaining very strong social bonds. It comes back to what Matthew was saying. It's about a caring community. So maintaining your social bonds, your social interactions, your social outings, to keep your mind occupied and remain curious and interested and mentally active, and to also care for your brain. It is a fine-tuned, beautiful piece of technology that you've got to look after. So you don't smoke too much, you don't drink too much, and you exercise regularly. And those things have been shown to be the things that come up trumps every time.
Fantastic, thank you. Anything to add, Matthew or Tim?
Yeah, I could add. Yeah, I'd like to add to that. Correct. I think keep socially active, cognitively active, and physically active, and that sounds easy. But now people want to know, well, how do I do it? What should I do? What specifically should I do? What should I eat? And now we're beginning to get the sort of more specifics out there. For example, from the dietary point of view, there's good evidence now following people over time with certain diets. least by association. There's a thing called the MIND diet, M-I-N-D, which is basically having lots of green vegetables, berry fruits, fish, chicken, reducing red meat, reducing butter, even reducing to some extent margarine, having olive oil, having cereal types, whole grains and so forth. If you look it up, you can see what the diet is, and there is good evidence now that if you follow people who stick to that diet, that cognitively those folks are better 4 or 5 years later. So now there's getting some specifics are coming out about what we can do, and then there's another study that came out this year at the Alzheimer's meeting in Canada about specific brain exercises, increasing processing speed, because there's a lot of sort of brain exercises out there, but some probably don't work that well and some work better. And so they're not, we don't know exactly what those ones are yet, but we're going to know what specific exercises brain-wise you should do. We certainly know that exercise is good, and already we know that in the Western world the incidence of Alzheimer's is going down. So we're all told about the tsunami of Alzheimer's disease, but actually the actual incidence, that's the number of people per year in any population developing Alzheimer's, is going down from what it was, and that's probably because of blood pressures being treated, cholesterol's being treated, people exercising and so forth. The absolute numbers are going up because we're living longer, but the number of people developing it. So there's a lot of hope already, and just to underscore what Matthew and Debbie were saying, you can do those things for yourself. I've got slightly more optimism than Matthew in terms of I think there's going to be real sort of simple tests to screen the population for potential Alzheimer's in the years to come. Exactly when I don't know. I think there's a huge amount of research going on. Nothing much has come from the drugs so far, just smidgens of success in the last year or two. But I think there are going to be some compounds that put together, a number of different compounds together, with lifestyle changes, which will make a real difference in the years to come. Yeah, so I'm pretty optimistic, Matthew. But I quite agree you need to have the caring approach as well, and not rely on the technology
Absolutely. Well, that segues me into the final question that I'm going to ask each of you. Matthew, I'll start with you. What do you know now that you didn't know 20 years ago, and what do you think you're going to know in 20 years' time?
Boyle's Law again.
Ignoring your previous prediction
in 20
quotes.
years' time, I'll have a better idea of how to look after myself. What I know, 20 years ago, I was a junior doctor who'd arrived in Christchurch in order to train in psychiatry, not knowing yet that older person's mental health was the thing that would grab my interest. And I was very naive and I was very young and I just wanted to help people. So I had that caring thing and didn't have much knowledge. So over 20 years, without wanting to hark back to the same point I've made before, I now know a lot about how the brain works, how the mind functions, medicines, drugs, technologies, and I think that caring is more important now than I did 20 years ago. That's it for me. Most of my practice is meeting people and looking them in the eye and saying, I'm very sorry to tell you, but you have a dementia illness. And I have people leaving my clinic saying, thank you very much. And it's not me, it's the whole team, but the approach is about the care of these people through a difficult moment. And so I really think what I know now is that my naivety was on the button.
That's a wonderful insight. Thank you, Matthew. Debbie?
So I think two things. It comes back to what I said before, that 20 years ago I was a physiotherapist, and that I think that the technology and our understanding of plasticity has increased enormously, and I find that exciting because I think that our understanding of the networks and things is just amazing. My other interest, of course, is multiple sclerosis, and when I first started looking after or caring for people with multiple sclerosis, there were no treatments. And everybody expected to get worse and to incur disability, and I looked after some people who really struggled. In the last 5 years, we have now 9 treatments for MS that we had before. We're spoiled for choice, and this is going to really change the lives of people who get multiple sclerosis today. And that is, nobody could have predicted that 10 years ago, and it is now just going to continue to increase, I think. And so it just shows that when a large group of people, scientists, patients, get together and focus on something, we saw it with HIV, that you can make changes.
Fabulous, thank you, Debbie. Tim?
Yeah, well, when I was, let's go back 30 years, when I emerged as a sort of a junior doctor, you couldn't get into the cardiac care unit unless you're under 50. If you're over 50, you just languished in the wards and you took your chances. Now you get in there at the age of 90 and you can have your heart attack treated and sort of reversed, and that's incredible. When I worked out at what was Sunnyside Hospital then in those days, now called Hill Morton, and used to live out there over the weekend, and most of my time was spent going to the wards where all the people with dementia lived, and you'd be going there stitching up people because they'd fallen over and so forth. That's where the dementia people languished in these sort of awful wards, with about some 40 people in the ward. And so now dementia care is a much different thing, and I'm right with Matthew there. So, the technologies and our understandings change people's care a lot, and the technology, I now know, that I can, that people with Alzheimer's, you can detect the changes in the brain, 15 years before with a PET scan that shows that we didn't know the abnormal proteins that cause these diseases. We do know them now. We know that there's a potential for early diagnosis, and we're just waiting. Our diagnostic tools have unfortunately been ahead of our treatment tools, but we're waiting with our diagnostic tools, which are very good now, to have the treatments. So we know an awful lot about the brain, a huge amount. When I first went to medicine, we thought the brain only had a certain number of cells, and that was it. But now we know the brain makes new cells, not particularly efficiently, but it does, and that causes hope. We know that the brain can make new connections all the time, even if we're 80 or 90 and we're having dementia, we can still make new connections by doing all the things we talked about lifestyle-wise. So, yeah, it's been incredible last 20 years, and we're going to learn an awful lot more in the next 20. I'm very optimistic.
Exciting, very exciting, thank you. Now, it's my turn for a plug, and I'm just going to talk very briefly about the Neurological Foundation Douglas Human Brain Bank, which started 20 years ago. It was founded by Professor Richard Fall, who is pictured here with his understudy, Dr. Morris Curtis. And they were part of a global team that actually proved that the brain can generate new cells. This was in 2007, and it was partially funded by the Neurological Foundation. The brain bank started 20 years ago, and its function was initially basically a resource that could store human tissue that was being offered by people that had neurological diseases, specifically Huntington's disease back in those days, so that Richard Fall and his colleagues could study what had gone on in the brain. Today, the Neurological Foundation funded the first freezer where the tissue was stored. It was a minus 80-degree freezer. Today there are 5 freezers, and they're very, very expensive freezers, but they do retain the brain in a way that it is able to be researched on in perpetuity, basically. Today we have in the brain bank the tissue from brains of 600 people. There are some controls in there, so some people who have what we call normal brains, and then there are disease brains. And the beauty of this facility is that people have died at various times and at various stages of their diseases, so the brains are actually staged so that the scientists and neurological researchers can see brain disease in its stages over the progression, and then get to know the patients because they have a relationship with the scientists over time, take notes of their symptoms, ask them how they are functioning cognitively, and give them the test that we talked about before for cognitive function. And it is an absolutely amazing resource that is used not only in New Zealand but also internationally now as well. And in 20 years' time, we think we'll probably have double that, obviously, but a lot more diseases, and I think we'll have the technology as well that is going to be able to get to cell-specific magnification so that we can see exactly what's going on in cell death in and potentially look at the mechanisms in disease at a much more microscopic level. So that is very, very exciting. I'd like to make mention of a special person who's pictured there as well, and that is Sir Graham Douglas, who sadly passed away a couple of weeks ago. That was quite sudden, and he'd been a long-term supporter of not only neurological research in New Zealand, but the Neurological Foundation and obviously the Human Brain Bank. And I'd like to pay tribute to his absolutely amazing commitment over a very, very long time. Ladies and gentlemen, we're going to ask our speakers some questions now, and Nina is going to manage that. And I think we're going to try and keep to one question, Nina, per person.
Thank you. Yes, I was interested in the difference between North and South Island of New Zealand.
With the multiple sclerosis study?
Yes.
Yes.
Are there any other studies internationally where Alzheimer's in a culture or country is extremely rare?
So the question was thinking about what Debbie shared with us about the great differences in multiple sclerosis depending on how close to the equator you live. Are there studies that say there are big differences in the rates of Alzheimer's disease, a different disease, across the world? There are no good studies that link that to countries. The rates, when they have been studied, are fairly well conserved. However, one of the difficulties is that the life expectancy in different countries is radically different, and age is by far the strongest risk factor for some of these illnesses, and that in countries where people might tend to die rather younger, the ability of science to do good studies to look at the prevalence of an illness is not great. And there are in fact 0 studies of the prevalence of dementia in New Zealand. So these are not easy questions to answer. However, what we can say is there are definitely some populations in the world, not countries, but specific, rather small and rather special populations where dementia illnesses appear to be very rare. The interesting thing about these populations, there's one in Italy, and there's one in Japan, and there's one in the Caucasian mountain regions of bottom of what used to be the USSR. These are people that live into their 90s and 100s. They don't tend to develop dementia illnesses. They don't tend to develop very many other things either. There's something going on, and they're of great interest to science, but they all exercise, they all have rich social networks, and they all have diets that are not dissimilar to the Mediterranean or mind diet that Tim described. So isn't that interesting? But there's something about their genes as well.
Yeah. Good question.
Can I just add, you may also ask, are there any animals that have Alzheimer's disease? And the answer is yes, there is. Aged cats are they about the only animal that have all the features of Alzheimer's disease in humans, and that is common. So if you've got cats that live a long time and they start to go off the boil, they've probably got Alzheimer's disease. and actually, talking about research in New Zealand, Gareth Morgan's got a point. I'm going to tell my fellow scientists that there's a whole menagerie out there of scientific material that's going to be coming their way.
Gareth will support that, Jim. Thank you. We'll go into the middle lot now. Middle section here.
Any questions from here? It's not so much a question, but just a thought. With the New Zealand's ageing population, the baby boomers, etc., and the children have flown, gone either in New Zealand, overseas, wherever. Just looking what I saw before about the caring and the interaction and keeping the mind sharp, I think perhaps Somerset, Ryman and these retirement villages might have something for the older population.
Clearly, there are big benefits to being in a community setting with people who might have similar interests to you, who might be at a similar stage in life, and where you can access help if you need it without having to move home. These are all big pluses. on the other hand, I'm very disturbed that in a society where we need to find an answer to the question, what are old people for? Because I'm not sure that as a culture we've got a good answer to that question anymore. Encouraging older people to rush away and live behind an effectively gated community of 150 village houses seems to me to be a backward step. And I meet people who come to me from retirement villages with such deep loneliness that I start to doubt the project.
There was a comment about mental activity of keeping people going. And there was also a comment that the taxi driver's memory exercises encourage growth of the hippocampus. Is it likely that a memory-based intellectual challenge would be better than one that's based on logic?
You're saying, would a memory exercise be better than one than sort of a logic-based exercise? I don't think we know the answer to that yet. So we know that sort of brain exercises seem to be quite good for maintaining some sort of brain health, but we still really don't know the type. The one that's only come that recently has been the one that's improved sort of processing speed. Speed of processing, that's been shown to sort of correlate with improvements in driving and so forth, and also in sort of some tests of cognition. But we still don't really know, and we're still trying to learn, and a lot of people are now looking at sort of prospective tests of, submitting people to different types of cognitive tests of the sort you mentioned, logic versus memory, say, and to find out what is the best test, to do. And we won't know, I don't think, for a few years yet. In the meantime, not knowing this, I think you have to do a broad range of cognitive sort of tests, and Sudoku and all the other things, crosswords and anything, things that increase your speed of reaction. And while you're waiting to hear what are the real tests that we should be doing. That's the best I can say. Matthew, have you got any other?
Yeah, I think we are. One of the things that we lack is good evidence that doing a test, doing an activity that exercises a certain mental muscle improves any other mental muscle, right? So that's what we're lacking. So then people start to come up with these sort of panels of things, and that may be a way forward. But let me tell you what I take from the literature and what I tell people at the moment, and we are largely in the dark, as Tim says. But what makes you different from your cat is that the social part of your brain and the language part of your brain are so greatly expanded compared to any other mammal on the planet. Whereas the Sudoku lobe of your brain is, it's not a massive portion of the whole. But the social part of your brain is. It has been said by neuroscientists that we have a social brain. Now, when you're meeting your mates or having a cup of tea with your family, you never know what they're going to do next. There's a certain degree of predictability, which is where memory comes in. You have to remember things about them, but it's constantly novel. It uses great tracts of your brain. If you sit people in a functional MRI scanner and get them to do long division, bits will light up, but if you stick them in a functional MRI scanner and get them to think about a conversation with a friend, we get a lot of activity. So be social. And Deb's other point about being curious, it's about doing new things. So this year, by all means, pick up Sudoku if you've not done it before, but that's not going to cut it after you're good at it. So next year, take up the trombone. And the year after that, think about the Gothic cathedrals of France. You just have to keep moving. And who says that that stops when you're 80? No one.
And Matthew, can you be social in a retirement village?
You can be social in a retirement village, so please don't take my comment to mean that I'm, they're not structurally antisocial. But people think that they're structurally social. It's all up to you.
Absolutely, good point, thank you. Thank you very much. Nina?
A lot of
talk about inflammation, and you talked, there was something earlier saying nerve cells are destroyed by inflammation and scarring. And I used to think of inflammation as being a red spot on your arm or something. Can you explain it? Because it's used in all sorts of areas of medicine now.
So inflammation is a situation which can occur anywhere in the body where you get movement of immune cells and white blood cells into areas of damage or areas of malfunction that then release a lot of what we call cytokines and factors that then propagate ongoing movement of immune cells in and out of an area. So take, for example, if you have a blood vessel and it has a bit of cholesterol in it, then the cholesterol will potentially cause problems with stroke. But what actually causes a clot to build up on blood vessels is that the cholesterol will burst and inflammation moves in to repair that. And it brings in white cells, it brings in platelets, and that is the process of inflammation. And generally speaking in the body, it's a healing type of phenomenon if you scratch yourself or if you have an infection. But it can also become dysregulated and propagate in areas that it shouldn't be in.
Yeah, and as Matthew mentioned earlier, about inflammation and things like Alzheimer's, we know that inflammation does play a part there in the central nervous system. And on that slide you can see there are some cells there that are inflammation cells that reside within the brain. They perform an important job, but when the changes of Alzheimer's and Parkinson's and those sorts of diseases start to occur, the inflammation becomes part of the process, and to some extent we think accelerates it, or at least helps it continue. It doesn't start off the process, but we think it sort of begets the process somehow. We haven't really managed to find sort of anti-inflammatory treatments that are going to be helpful, not yet, but people are looking at that aspect. So it does seem to be part of the neurodegenerative process, but we're not quite sure exactly what role or how important the role it is.
Good.
It is exciting, I think, for us to know and to know more about the brain, but also to consider the progress into the coming years. So thank you so much for your remarkable insights, for your time tonight, and for doing what you do. I think you've helped us realise that we actually have quite an amazing ageing brain, not just an ageing brain. Sue, thank you so much for your chairmanship tonight. To the Neurological Foundation team that's here, Jan, who's based here in Christchurch. Georgie, thank you for putting on tonight. It's been fantastic. To all our members and supporters of the Neurological Foundation, thank you for your commitment. We can only do this with people like yourselves. And we do hope that you continue with us on our journey. For others who might be wanting more information, you have got our newsletter on your seats. Inside here in the middle is a little form that you can fill out. $5 a year, you can get 4 of these a year. Lots of information about these people here. I would like to finish just with words from an American physicist, I better get these titles right, Emerson Pugh. He said many years ago, he said, if the brain was so simple that we could understand it, we would be so simple that we couldn't. However, I think over time, and I think this is what Dr. Croucher said, with research, we are improving quality of life, we are improving the enjoyment of life. And with our increasing understanding of the brain, how it works, how it develops, how it malfunctions, but how it repairs itself as well, we, together, may one day demonstrate that Dr. Pugh underestimated the power of research. Good night, everyone. Thank you very much.
Thank you.